Good afternoon, everybody. Thank you for joining Asthma Canada and our special guest, Dr. Alan Kaplan, for this very important webinar today regarding COVID-19 and asthma. Um, I will let you know who I am. My name is Jonathan Kirby. I'm the manager of programs and services here at Asthma Canada, and I will be your moderator. Um, and right off the bat, I just want to again thank everyone for joining us today. We will go over some frequently asked questions that have been presented to us throughout the last couple of weeks. And if you have any more, please put them in the attendee chat if you have a chance. We may only get to one or two, and just have put a note in there, and maybe we might be able to get to it. And without further ado, I will hand it over to Dr. Alan Kaplan. And Dr. Kaplan, when you're ready.
Thanks, Jonathan. Thank you, everyone, for joining us. This is a very interesting time we're in right now, and I'm happy to be able to share a little bit of knowledge about it. I understand I'm speaking to everybody from patients to healthcare practitioners. I hope that I'll be able to speak at a level that we're all able to understand and join together. I'm a family physician first and foremost, but I share something called the Family Physician Airways Group of Canada, which is a group with an interest in respiratory medicine. Our mission statement is to improve respiratory management across the country. I'm involved in a number of other respiratory initiatives, as you can read here on the slide. But the bottom line here is that we want to work together to make sure we can limit this pandemic. Next slide, please. So I want to go over the story, where this has come from and where we're going, the risks, and particularly, I know we have a lot of people with asthma and respiratory illness on the line, so I want to talk about the risk, particularly with regard to asthma. What we can do to prevent the illness, what we can do as far as your asthma, and what perhaps you should not be doing. I think that might be as important as what you should be doing. Next slide, please. I have no disclosures when it comes to having to do with anything to do with COVID. I give a lot of presentations for a lot of the companies that make respiratory products. I also sit on a couple of government committees as well. Nothing I think is going to be relevant to this particular conversation. Next slide, please. So I have a few messages. The first couple slides now, we'll come back to them at the end. And if you take anything out of this, it's these messages, please. The first thing is, as far as your asthma, keep taking your medication. Do not stop it. There's some fallacies out there about medications being dangerous for you. It's not true. I'll talk about that more specifically. But please, as far as your asthma and most other things, do not take your medications, because what's happening is we're seeing people who are having flares up of their other illnesses because in a mistaken attempt to help themselves are stopping their medicine. So don't do that. Number two, wash your hands. We'll talk about how this virus is transmitted, but the single biggest thing you can do to prevent catching it and spreading it is washing your hands. And wash your hands means soap and water, at least 20, probably 30 seconds, gives a good scrub, get between the fingers, and so on. Number three, and you've all been listening to the news, talks about social distancing and physical distance, and you want to stay 6 feet away from people in situations. I'll explain why in a moment. The travel issue is now probably a little bit late in the story. When this initially came from China, it became something that was transmitted by people traveling from other places. Then it became Italy and Spain and Korea and so on. But now, travel is not the vector. It's the most important thing. Now we have community travel, so I'm going to come back to that as well. Next slide, please. But of course, we shouldn't be traveling. Now, we also want to make sure that we clean the surfaces around us. We want to make sure the virus is living on any of the fomites around us, whether it's toys and phones or door handles or even your phone or your computer screen. Number six, it has to get introduced to your respiratory tract. So if you keep your hands away from your face, eyes, ears, nose, and mouth, you're less likely to infect yourself. Number seven, if you're sick, get help. If it's your asthma, you're sure it's your asthma, you don't have any fever or anything like that, then activate your action plan. We'll talk about that. But if you're getting a fever and you're getting short of breath, we have to make sure that it's not the COVID presenting and getting sicker. So speak to your clinician about that. And the last thing is, please stay home. I mean, what we really want to do here is we want to prevent this pandemic from everybody. And that really is such a key message, and I can't echo enough what Health Canada is doing. We have to limit your contact with other groups. And just in Ontario now, they have limited groups to no more than 5 people. really, you shouldn't be congregating at all, and you shouldn't be groups of other people at all unless you absolutely have to. Next slide, please. So what is this coronavirus? Well, it's a virus that occurs initially in animals, and of course it can spread to humans, which up until recently has been fairly rare. But as you know, there's been a number of different coronavirus infections that have actually flared up and traveled into humans, like SARS, which is severe acute respiratory syndrome, and MERS, Middle East respiratory syndrome. These are two different coronavirus infections that happened over the last number of years that were very much respiratory illnesses that were transmitted by cough and respiratory droplets. However, in December 2019, information came out of China that there was a new coronavirus starting to spread there. The theory was it was caught at a fish and live animal market. I'll talk a little bit more about that. And of course, now it can spread from person to person. The timing is important, and you'll understand why we talk about the quarantine of 14 days, because symptoms can occur anywhere from 2 to 14 days after coming in contact with the virus. So that's how long you have to be symptom-free before you know you don't have the infection. And of course, you all know this has become a global pandemic, which means an outbreak of a new virus that spreads easily. Next slide, please. So what happened here is that the Chinese authorities detected this epidemic and the increased risk of pneumonic illnesses. And then there became, of course, human-to-human transmission after a single introduction in the human population. So the theory here is it was introduced from an animal to a single person to spread it to other people. Now, there's an animal called a pangolin, which is an armadillo-like mammal that lives in Asia and Africa. And it's got a ribonucleotide structure very similar to CARS-CoV-2. So the theory is that the coronavirus from a pangolin could have been transmitted to human either directly or through intermediate hosts, such as ferrets and other animals. There's also some theories, of course, that it may be related to bats. And in bat droppings, you have things that fall down onto animals, especially in markets. So this is what a pangolin looks like. It's a cute little creature. And if you look at the next slide, you'll see that they sort of hang around in trees. They're very innocuous. They don't bother anybody, but they get hunted. And once they're hunted, they then get killed. And they're put into markets like this where they're sold as a delicacy in Chinese markets. So they're hanging up in markets like this, carcasses lying down there, with other things lined up around them, which is, of course, a terrific breeding ground if something was to them be transmitted. And the theory is that it got transmitted in a market to a human person who then transmitted to other human people, and then it got worse from there. Next slide, please. So the symptoms, and you've been barraged by this, so forgive me as I say things I'm sure many of you already know, but I'm going to go back to the basics and then move forward from there. And the symptoms here are the combination of these things. And these are not dissimilar to influenza. Influenza is a little bit different, where you get a sudden onset of fever, cough, and myalgias. The shortness of breath is a little bit later. But in this syndrome, then it's these things all together. And shortness of breath is the thing that really gets us more concerned. The fever and the dry cough is not, it's usually a dry cough. And the fatigue and so on that occurs is a symptom of any virus. It's the progressive shortness of breath that becomes a little bit scary. Next slide. Now, in addition, we're recognizing that there are some other symptoms that are not uncommon. Gastrointestinal symptoms, diarrhea, and so on. I have a message here that my voice is going in and out. Please let me know if I haven't fixed it. I've moved it closer to my face. Gastrointestinal symptoms and diarrhea may be the first presentation, and we've learned more and more about this. Something that's actually very interesting is the loss of the taste and smell that's occurred in patients, more persistent with this situation than others. And about 10% of people can actually present with conjunctivitis as well. I learned that from my daughter, who's an optometrist. So this loss of taste and smell is very interesting. So as you know, when you get a stuffy nose, you have an inability to smell, and that's very common. But this seems to be a little bit more specific to the coronavirus. Next slide, please. So how does it spread? Well, like most respiratory illnesses, it spread through coughing or sneezing. The viruses then are in droplets, and those droplets are coughed out in the air. Now, what's a little bit different about this than some of the others, it's actually quite a heavy droplet, and they very quickly fall down to the ground on the surface, but they will go about 2 meters, which is about 6 feet. So if you get sneezed on or coughed on within 6 feet, you may well be in that zone where the droplets can reach you. A cough goes about 6 feet. By the way, a sneeze can go in actually quite a bit further. It's quite a forceful thing, a sneeze. It can reach more than that. So even 6 feet, you're not entirely safe. So therefore, if someone coughs near your face, you can get infected. And that's why if someone's around you is going to cough, they should cough or sneeze into their elbows or into a tissue, then throw it away, and then, of course, wash their hands. Now, we're going to talk a little bit more about masks in a little while. But The idea here is that if you're sick and you have an illness, wearing a mask, of course, blocks you from coughing and sneezing that virus out into the air. So the major value of wearing a mask is to stop spreading the illness. Now, it lives on surfaces for a long time, up to 72 hours. Some things a little longer than others. It can live on cloth and metal. Interesting, copper, for some reason, it doesn't last very long on copper. So maybe we're going to find a use for all those pennies we've got that we're not using anymore. But for the most part, it can hang around for up to 3 days. So if you touch a surface that has virus on it, and when you touch your eyes, nose, or mouth, you may actually get sick. Next slide, please. So these numbers are changing every day. And so we've updated this as to March 29th, which is yesterday. We have some 600,000 cases, but it's actually more than that already. Deaths, we have over 30,000 cases. And right now, as you know, China was the initial, and then Italy and Spain have become more heavily hit, and now the United States has become the epicenter of the illness. Very common in Germany as well, which is interesting because they're a very rigid society, but yet it's spread right through there as well. And of course, the more social distancing, the more the things are done to prevent, the better it's going to be. But the good news, as you know, is Wuhan is now starting to open up its businesses again. It's 2 months later, and they've now recognized that things are slowing down, and they can start trying to get their life back to normal. So the end is not nigh. We're not right there. It is going to get better, and I'm going to talk about that at the end as well. Next slide, please. The Canadian data, again, as of today, 6,000 confirmed cases, 66 deaths. Hardest hit is Quebec. The number 2 per capita is actually Newfoundland and Labrador. There was a number of patients who went to a couple of funerals apparently in Newfoundland, and it spread quite extensively there. So we have quite a bit across the country. Now these numbers, that's a lot of cases, 6,000 cases, but if you recognize that the incubation period is up to 2 weeks, that the testing takes as much as a week to get results back, this is strictly the tip of the iceberg. And we'll talk about testing a little bit, but I can tell you is now that we're not completely testing all our patients because we don't have the resources. So these numbers are significantly underreporting. Next slide, please. So how does it present? Well, obviously, when people are really sick, it presents with a pneumonia, rapidly progressive pneumonia. But the most common presentation is nothing at all. It's an asymptomatic carrier state. So recognizing that a lot of people can be carrying this, especially younger people, and not know they have the illness at all. Now, adults, of course, have the highest infection rate, but children and young adults can also get this. And in fact, even neonates can get this. And there's been recognized some vertical transmission of COVID-19 from pregnant moms to their neonates. Fortunately, they tend to do well. And this is not like H1N1, where pregnant women tended to have a significant burden of illness in H1N1. It doesn't seem to be the same thing when it comes to COVID-19. Young people are not getting terribly sick with this. Doesn't mean they won't get sick. It doesn't mean they can't get sick, but the numbers are not quite as high. And of course, a vector that we've recognized as well is healthcare workers. And we know that in Italy, I think the number is something like 10% of healthcare workers or 15% actually got infected. And therefore, there's even some deaths in the healthcare workers. So we have to recognize where the vectors are. It's us moving from person to person, and even people who are trying to help may actually get infected and transmit it to other people. Next slide, please. So the highest risk groups initially, according to the World Health Organization, CDC, were people who traveled. I think that's actually an academic conversation now. Now we're getting community spread. The travel spread is no longer the big issue. Interestingly, in China, the new cases they had in China are people who come back to China from other places. So now they're getting a second wave of people who have travel related. But here, I think most of our travel related patients have already come in, except for those people who are on cruise ships still. But other than that, most of the community spread. So who are the people at risk? Well, people who are caring for people who are ill. Because we know from SARS, the sicker you are, the more virus you shed. So if you're caring for someone who's ill with coronavirus, then you're at risk. And I just heard about a nursing home in the Kawartha Lakes, where I think 7 or 8 people have died of the illness, and one person who was the spouse of one of the people in the nursing home, who was volunteering at the nursing home, also passed away from the illness. That leads us then to people over the age of 60, and they're finding from the epidemiology in China that people who have cardiovascular disease, hypertension, diabetes, not so much chronic lung disease, but we're going to talk about that, but mostly diabetes and cardiovascular disease are the ones who had the highest risk of dying. Next slide, please. So again, how do we avoid COVID-19? I've said this, but I think it's worth re-saying, so I'm going to say it a few times. Okay, it's a heavy droplet. It gets onto surfaces and lives there. So your best way of preventing illness is washing your hands and washing it off. 20 to 30 seconds every time after you cough. And if you don't have soap, and soap and water is plenty. You don't need to buy expensive, fancy sanitizers and cleansers and stuff like that. You just need to wash your hands with soap and water. Now, if you don't have access to running water, some of you are in the hospitals, you're walking up and down halls. We have lots of alcohol-based cleansers up on the wards, so you can use that. But of course, in addition to that, even if it is on your hands, as long as you don't touch your eyes, nose, or mouth, then you are not going to transmit it to yourself. So again, staying away from people who are sick and staying with people who've had contact with someone who's sick. And right now, frankly, it's stay away from almost everyone. I mean, that's the rules. Ontario, five people gatherings, right? It's really disappointing that this last weekend in Ontario we had nice weather, but young people were ignoring the social distancing rules and getting together in groups and doing things. That's a very short-sighted view, of course. Don't share things that may have virus on it. And as far as the asthma, just keep taking your regular medications. Next slide, please. Good question. I see, what about biting your nails? That's a really good question. Biting your nails is going to have your hands in your mouth. Bad habit. Shouldn't be doing it. I even saw something in the optometry literature that suggested maybe people shouldn't be wearing their contacts. They should be using glasses now. Again, less things to put in their eyes. So this little cartoon talks about what do we have in terms of an antivirus. We don't have an antivirus right now. I'm going to talk about medications in a little bit. We don't have a vaccine yet. They're working on it. So the best antivirus we have is #stay at home. Prevent the spread by preventing the direct inoculation to others. Next slide, please. Now, you've heard a lot about this flatten the curve, so I wanted to explain what this meant. What happens in a pandemic is we have this sudden, overwhelming number of people. That's the sort of the first number one bar there, that peak. And because so many people get sick quickly, and people are requiring very significant resources to support them through this, which includes hospitalizations, ICU stays, ventilators, intubation, intensive care unit people, it just overwhelms by sheer numbers, the number of people who are available and the number of resources available to look after it. So if we can flatten that curve or slow down the pandemic, so it's not even necessarily having less people altogether, but hopefully we can have less people, but also having those people sick over a longer period of time, which means people get sick, they can be looked after, and then they can go home. And when they go home, the next round of people who are sick can be in the hospital and they can be looked after. And by not overwhelming our resources, we can actually decrease overall numbers, but also decrease deaths because we're preventing this overloading of the system. Next slide, please. I want to show you what happens in the Spanish flu in 1918. It's A Tale of Two Cities, an old Dickens book. This Tale of Two Cities is a bit different. So in Philadelphia, when Spanish flu was initially reported, Philadelphia officials downplayed how important this was, kind of like, unfortunately, like President Trump did this time. He didn't think it was terribly important. He was trying to reassure everyone it's not a big deal. Well, you know what's happening in the States now. But in Philadelphia, they didn't do anything different. They had a very significant peak of the illness with lots of deaths. In St. Louis, another United States city, they took a very different approach. They banned public gatherings. They stopped school. They stopped and they had social distancing in 1918. And look at the difference in the death rate and the peaks that occurred in St. Louis versus Philadelphia. That's what we're aiming for here. We're aiming to flatten that curve and prevent deaths by being able to keep our, next slide please, being able to keep our patients looked after. You know, and this is what it looked like in a picture from 1918 in terms of hospitals. And the scary thing is this is what it's looking like now. Look at the images that are coming out of New York as they're building field-based hospitals in Central Park to look after people. We're just overwhelming our resources. We don't have enough people to look after the sick people. Let's flatten the curve. And we do that by staying at home. Next slide, please. Now, this is some Italian mayors who are going to share their opinion of people not listening to social distancing. You can read the subcapitals. These are mayors walking up to people outside saying, behave yourself. I don't care if you're soaking your feet in water. Go home. Don't be playing ping pong on the beach. It's not okay. You need to go home yourself. Next mayor, don't leave your house. It's an order, so watch out. This guy is my favorite guy. People are dying. Don't you get it? You want us all to get ill. We can stop there. colossal idiots. Right? So we have a situation here like in Italy. In Italy, they have 10,000 or some odd deaths. They needed to make some differences. They made those rules, but people didn't all keep to it. You can see the rants of the different mayors, and I give them credit for them trying so hard. A little about terminology. What does isolation means? Well, what isolation means is you want to separate the sick people from the well people. Very simple. If people are well, they're not exposed, they're not going to get sick. Quarantine is taking someone who is either sick or was exposed to an illness and keep them restricted, so just in case they might have the illness, they're not going to give it to someone else. Next slide, please. So what's the difference between these things? So self-quarantine means staying in a place, either at home or elsewhere, again, that 2-week period, because that's the incubation period, because you've been exposed to or you've been tested positive for. So either way, theoretically, you could have the illness, so you're going to be staying at home, staying away from everyone else for 14 days until your illness has settled down. Once you have symptoms, then you're going to be excreting a lot more virus potentially, and that's when we talk about self-isolation as well, which is not terrifically different, but the point here is you need to be staying away from everybody at this point because for sure you're going to be transmissible. And the concept of social distancing is just keeping away from other people. You're not shaking hands, you're not hugging people. One of the theories about why it's so bad in Italy is because in Italy the traditional greeting is a hug and a kiss on both cheeks. Well, I think that may be changed now in the future. So we want to keep away from other people. Next slide, please. I'm sure you've all got this in your paper, in your newspaper. We got it this weekend. It just defines the different rules for self-isolation, self-monitoring, and frank isolation. Isolation, if you have, if again you want to stay away from other people. Self-isolation is you keep away from everybody, including your family. Self-monitoring means well, you've potentially been exposed, you're a little bit worried, so now you got to pay attention. And you have no symptoms, maybe you got exposed, so pay attention to yourself. Take your temperature, keep yourself away from other people, certainly avoid crowded places. So these are all drifting into each other. As we say, basically, stay away from everybody else and prevent spreading the illness. Next slide, please. So some practicalities, because I know there's a lot of you out there that are saying, okay, I know I'm supposed to do the social distancing. What am I allowed to do? What am I not allowed to do? Well, you don't have to stay inside locked in a room. That's not true. Now, if you're sick, you probably should be doing exactly that. But if you're just social distancing, you can go outside, you can go for a walk, but keep that 2-meter distance because, again, you don't want to be within a cough of someone within 2 meters because they can get it on you, right? You want to be careful what you're touching when you're walking right outside because you don't know who has touched what as you're out there, right? So overall, limiting contact, especially in crowded places. Now, there's some very practical things with that. You have to get food. You may have to pick up medications. You have to refill your puffers and so on. So there are ways you can do that. There's grocerygateway.com in a lot of places. Medications can be delivered from the pharmacy and so on. But if you have to go, go. And when you go, before you leave, you wash your hands. You touch only the stuff you have to touch when you're there. And when you get home, you unpack stuff, give things a wipe down, and wash your hands once again. Okay. If you're really worried, you can wear masks. We can talk a little bit more about that. I don't think masks are terribly as important as we think. But again, stay home as much as possible. Do what you have to do. Go out, get your food, get your prescriptions, get your stuff from Home Hardware if you want to build something and do something at home. And then when you come home, importantly, wash your hands. Next slide, please. A really nice request here, question I got here. I live on the 25th floor in a building with an elevator. How do I stay 2 meters in the elevator? It's hard to walk up 25 flights of stairs when I have asthma. Well, if you have asthma, you shouldn't be limited by your asthma, so you should be able to walk up 25 flights of stairs, but fitness might be the bigger goal there. And if your asthma is limiting you, then your asthma needs to be more aggressively managed. But you're right, it's hard. We have rules in the hospital, only so many people can get on an elevator at one time just for this social distancing. So again, same thing. If you're going to get into an elevator, okay, you put a scarf over your mouth. If you're worried about someone coughing near you, you stay as far away as you can from anyone else. You touch the elevator button. You don't touch your face. When you get back to your apartment, you wash your hands. Similar message. How do we do this? Well, it's now getting to the point where clinically is probably enough. Because if you think you have it, if you think you're exposed to it, rather than doing swabs and serology, which is coming, you have to self-isolate anyhow. Right? So that's what's really important here. And now we're finding we don't have enough swabs, and less are we swabbing everyone. Initially, it's very important to swab everyone so we know we have this pandemic epidemic. but now it's actually not going to change the behavior for most of us who are not sick with it. We have to swab people sometimes to make sure they're safe for others. So healthcare practitioners are often getting swabbed if they've had exposure so they can know whether they can go back to work. And in a hospital setting, where I work in a hospital setting where we admit patients with other problems than COVID as well, in those situations, if they had a potential exposure, then we swab them to make sure they're not going to be infectious to someone else, especially if they have any symptoms like a fever. And people get admitted to a hospital with fever who don't have COVID. There's other things that cause it, urinary tract infections, other viral infections. Sometimes we have to swab just to make sure they're safe to be exposed to other people. There is serology coming. It's being worked on now. We're going to probably have that fairly soon. I think that's going to be very important for diagnosing people who have had the illness to see if they're immune or not. This is all going to change things down the road. And of course, there are other things that cause fever and cough. So we can have bacterial pneumonias and so on, although fortunately we don't seem to be having a lot of that. We can have exacerbations of COPD and asthma that can cause cough. So sometimes we have to figure it out for those reasons. Next slide. So for the clinicians in the audience, there's a wonderful website called covidcriticalcare.ca that you just have a look at. And it gives a lot of information for treating people in the hospital, as well as how to decide who should be swabbed and so on. Next slide. And the people that should be swabbed, and this is our current recommendations at OSLR where I work, and this is being changed every day now. So this is as of a couple of days ago. But if you're coming and being seen in a COVID assessment center, as you know, there's a lot of those set up everywhere now. We actually have very small numbers in our emergency room, but we have lots of people in the COVID assessment center. So who gets swabbed? Well, if you come in and you're not very sick, you have a bit of a fever, okay, but otherwise you're not sick, you're probably not going to get a swab. You're going to be told to go home and self-isolate after an examination to make sure it's not something else. But you're going to be swabbed if you have respiratory symptoms and a fever, and there's something else. You're older, you're immunocompromised, and I'll define what immunocompromised means in a minute. If you're living in a facility where it could spread aggressively, like a long-term care home, or if you're a healthcare worker, and because of reserve situations where people are crowded together, it's being done a little more liberally there as well. Now, one of the issues that happens here is this virus attacks something called ACE2 cells in the lung. And these ACE2 cells in the lung then cause cough and chills and fever. What happens after that, after a few days of illness, if you're unlucky and your immune system is not strong, there's something called a cytokine storm that occurs. And that cytokine storm then overwhelms the immune system and causes inflammation in the heart and other organ failure and acute adult respiratory distress syndrome, and that's what causes people to unfortunately pass away. So your immune system is a little compromised if you have a disease of the immune system like HIV or lymphoma, if you're on chemotherapy for cancer, if you're on biologic agents for rheumatoid arthritis and colitis and things like that, and if you have significant renal insufficiency, bad enough to be actually on dialysis, we know your immune system is compromised then. So these are the people who really should be avoiding everybody else right now as much as they can to prevent getting this illness, because they're the ones who are highest risk of dying of this illness. Next slide, please. If you're admitted to the hospital, so that's going to be a smaller number of people, they get a swab if there's evidence radiologically of pneumonia, or an influenza-like illness, or new respiratory symptoms, or for an asthmatic or COPD patient, worsening of a pre-existing respiratory condition, because you want to know if it's the virus or not. If there's a fever without another cause, I remember I said at the beginning, GI symptoms are one of the presenting factors as well. So if you're sick enough to end up in the hospital, the swabs are done a little bit more readily. Next slide, please. Unfortunately, the swabs are not perfect. So depending on how much virus is being shed at the time of the illness, an initial swab might be negative. So in terms of the hospital setting, especially in the ICU setting, if your COVID swab was negative, but you get sicker and sicker, so you had a situation, you perhaps had exposure, you got swabbed, it was negative, but then a few days later you got very sick, you ended up in the ICU, then we believe it probably is COVID. We'll probably re-swab and treat you as if you have COVID, but looking for other things at the same time. So the swabs and the serology are not 100% yet. Next slide, please. So I thought I'd then break this down into some questions. I'm seeing some of these questions being asked in the messages, so thank you. So hopefully these are going to answer a lot of these questions that we should. I see a question about severe asthma. Again, it's about whether or not asthma overall is going to be an issue. So are people with asthma more likely to catch COVID-19? And the answer is no. What if you have severe asthma? No. What if you're on an asthma biologic? We're worried about immunity. Well, the answer again is no, because asthma biologics do not affect your immune system the same way as like Th2, same as Th helper cell biologics, like Remicade and biologics for rheumatoid arthritis and so on does. So you're not more likely to get COVID because of your asthma. So big breath, we're all okay. Next slide. What about outcomes? So if you have asthma and you get COVID, are your outcomes going to be worse? Well, some studies out of China, and of course this is all in development, so we're going to learn more as we go. So this, some of these answers may change over time, to be fair. But the slide I'm going to show you, the study in a moment, showed that there's no effect of COVID on asthma. If you're sick enough to require intubation for any illness, and that could happen to anybody, while the mortality is 80% people who are over 60, there are still 20% of people who die who are younger than 60. Some of them quite young, receiving intubations at sick children's. So just the other illness, if you're sick enough to end up on a ventilator, it's going to affect your lungs potentially. You're going to need a lot of rehab and so on. So we don't know whether COVID particularly worsens the asthma itself right now. All viruses can worsen asthma, as we know. All respiratory viruses can worsen asthma. So we're just going to have to see with this answer right now. I can't tell you that answer just yet. Next slide. So this is the study from Wuhan looking at 140 patients infected, and they asked a question, a good question, well, asthmatic patients or even COPD patients, frankly, have a higher risk for getting the virus, and the answer was no. Older age, comorbidities, especially cardiovascular diabetes, seem to be the highest risk, and one of the causes of death, unfortunately, in the COVID is the involvement in the heart. And the myocarditis and cardiomyopathy that occurs is probably the more common reason for one of the more common reasons for the death that occurs. So those comorbidities are more important. So age, cardiovascular illnesses, diabetes, hypertension seem to be the bigger issues. And they're starting to recognize some things that seem to cause worsening outcomes or related to worsening outcomes. The bone marrow is important. So lymphopenia, decreased lymph counts, and blood eosinophils going down, which is the opposite of asthma. Blood eosinophil counts tend to be related to poor outcomes. And then levels of things like D-dimer and C-reactive protein are all things that are associated with cardio and beta-natriuretic peptide. Things are associated with cardiovascular issues. Next slide. So should I wear a mask? Well, there's a lot of masks out there. It's interesting because Japan is one of the countries that have done the best with the curves. Japanese people, as a rule, are more reserved. They don't hug. They keep their distances to start with. And as you know, in the Asian countries, masks are a very common thing to wear even before this pandemic. So one of the thoughts was that was going to be an improvement, but in fact, they just had a recent jump up in cases in Japan as well. So I'm not sure that the masks actually make that big difference. If you're coughing, you want to wear a mask to prevent somebody else from getting it. But is it going to stop you from getting it? The only way it'll stop you from getting it is if hands and you touch the mask rather than your mouth, you're less likely to get it. So again, wash your hands or hand sanitizer if not. And again, if you've got it, you want to prevent spreading to anyone else. So why not just wear a mask, everybody? Sure, it's great, fine. If everybody wears a mask, we're going to run out. And if we run out, then what's going to happen? And we already know that there's supply chain issues. One of the biggest issues that we're having now is personal protective gear for healthcare workers. That's not just the masks you can sort of buy over the store. It also includes gowns and face shields and things like that. But this is something we have to think about in terms of the big picture here. So our hospital just recently instituted that all the staff coming into the hospital, anybody walking into the hospital, and they don't let visitors in, so just staff, now has to wear a mask all day in the hospital. I think that's probably overkill, but that's their new rules. Next slide. If you look at what the World Health Organization has said, so this is your healthcare worker, and especially working in a situation where droplets are an issue, someone's actively sick, then you want to wear not just a mask, but a proper N95 mask. You want to wear a gown. You want to wear a head cover because it's been known to sit in hair for a little while. You want a glove, of course, and you want to put them on properly and take them off properly. So many of you are healthcare practitioners, with sick patients, it's important. The technique is important. For instance, okay, you take off your mask. You take your mask off from behind your ears, not from the front of your face, where you could infect your face. Next slide, please. So the World Health Organization has said, no, we don't need to wear masks in public for everyone. Washing is more important. And for asthmatic patients, of course, it's not comfortable to wear a mask. And if you're already feeling a little short of breath and anxious, it may make that worse. So there's some downside to wearing a mask. But of course, more importantly, take your medication. And flu shots, this year it's probably a little late for influenza shots already. But down the road, please get your flu shots every year. This is a really important step. Next slide, please. So this is the World Health Organization on masks, and I see that Teresa, thank you for joining us. Dr. Tam, our Chief Medical Officer, has said that everyone should wear a mask now because it's airborne. Again, it's only going to be airborne about 6 feet. So if you're not getting coughed on, I'm not sure that we have to worry about this. This is not SARS where it's going to sit up in the room for much longer. So their recommendations, masks are not required for people who are not sick. However, I know many of you feel that you want to do this to protect yourself. I think the major reason why masks may protect you is if someone does cough near you or you touch a surface that has COVID on it, and then you touch your face because it's itchy. If you have a mask, you literally have a barrier. And that's why there may be some benefit just using a scarf, or some of the masks that are being created now that, with cloth in it and so on. It just may decrease the viral load and prevent you from touching your face. Next slide, please. So if you're going to wear a mask, then wear it properly. I can't tell you the number of people I see walking with a mask on their chin. It's not covering their nose. You have it hanging on one ear. If you're going to do that, it's not helping you. Try not to touch the mask while you're wearing it. Okay? Make sure it's tied down properly. If you're having an N95, it must be fit properly. Don't wash your mask with alcohol-based cleanser soaps, because then the mask is going to be wet. It does not protect you as much. If the mask gets wet, throw it out. You're not supposed to be reusing single-use masks. Use common sense on that. If it's gotten wet or dirty, you shouldn't be reusing it. And throw them out properly. My goodness, I see on the ground now, there's gloves sitting on the floor, there's masks on the ground. People are just throwing stuff onto the ground. That's horrible. And because it puts people who are cleaning up at risk. So what I want you to do is I want you to take that and throw it out properly, dispose of it properly. A good question here was, well, if I'm coughing because of my asthma, the public will want me to wear a mask. Really good point. I mean, you're going to be people around you are going to be very anxious if you're coughing. So I think to prevent other people, it's not unreasonable for you to wear a mask if you're coughing for other reasons. Even if you know yourself it's not asthma, but if you're going to cough in a room, people in that room are going to get pretty freaked out. So I think that's a very sensitive thing to do for other people, to use that mask in that situation. But you can just use that cheap regular mask, or just even use a scarf. So how do you self-isolate? And this was a question some of you asked. How do we do this at home? What's the practicality of it? If you have someone who's sick, okay, remember, someone who's sick, they've had a bit of a fever, a bit of a cough, you think they might have COVID or they're confirmed, you want a place where they're not going through common rooms, not traveling through the kitchen. They've got their own bathroom, their own towels, their own Kleenex, their own soap and water, okay? And nobody else is going into that room. Now, if it's a sick child, that's a little obviously difficult. Someone else is going to have to. And people who are caring for someone who's sick are going to have to use appropriate precautions, right? So if you have been involved with someone, that's probably a good time to wear a mask. If you're actually exposed to someone who's sick, and either wear gloves and throw them out, but better yet, just wash your hands and don't touch your face, right? And clean the areas around. Recognize everything in that room is going to be covered with virus within 6 feet, right? And sneezing even further. So everything has to be wiped down. Right? So if you're if you're isolating from other people, you take your own place, stay away. Tell people who children will live downstairs in the basement, or a sick person will live down in the basement. Everyone else lives upstairs, and so on. And therefore, we can be doing that. So just think about what you're doing. Think about where you could get it from. You could be coughed on and sneezed on, or you could touch a surface that has the virus on it. So either everything's clean or everything's assumed to be infected, and you wash your hands accordingly and don't touch your face to prevent getting infected. I hope that's made it sort of clear how to try to do this. Next slide. So what if you get a fever and a cough? Well, if you've got a fever, you've got an illness. So you have to understand that there's something going on causing a fever. Fever is a reaction to an illness. It's not the illness itself. It's your body mounting an illness, right? Mounting response to the illness. So if you've got a fever, you have to decide why you have a fever. Okay. Up until recently, we say with fever, you got a little bit of a virus, don't worry about it. Well, now we have a virus that you're going to worry about it. So you should contact your clinician, your physician, okay, and the different call centers. And there's different risks strategy documents you can get online to see how sick you are, whether you should go get tested or not. But the bottom line is, if you think that you've got, even if you have asthma and you have a cough without the fever, is it your asthma? You mostly know your own asthma. Is it an asthma flare for which you've taken a little bit of a rescue medication, you feel better? Or, is this something different? I'm coughing a little bit differently. I'm ill. That's different. And if you are ill, you don't go, obviously no one's going to work or school now anyhow. You don't want to spread your illness among anybody in your home, right? So remember, especially if you have an elderly parent or a grandparent at home or someone with a comorbidity, you want to make sure not to spread it. So think about that. The other thing is, if you are a little bit short of breath, and you're not convinced it's the asthma, and frankly, even if you are convinced it's asthma, be careful, because we know that the illness is biphasic. The first part is the viral syndrome, the fever, the aches and cough and so on. And then if you're unlucky, you get this rapid, significant, quick drop. So even people who have been tested and sent home are being told that they really need to check in with someone every day. And if respiratory function starts to worsen, you start getting more short of breath, you need to go to the hospital, because you can crash very quickly. Not just asthmatic, but anybody. Asthma is not worse, but anybody. If you're getting short of breath, okay, as if you're sure it's your asthma, okay. But if you're not sure it's your asthma, then you better get seen, because people sometimes do very poorly, as you know, with this illness. Next slide, please. So if I think I have COVID-19, what do I do? Sudden onset of flu-like symptoms, fever, cough, shortness of breath. Isolate. Call your clinician. Okay. If you're showing symptoms, then again, social distancing, self-isolation, as we talked about, and you can try calling your local public health authority and get some instructions from there. You can go on the online tool that asks you a series of 8 questions to see whether you're sick enough to go to the hospital. I warn you that I just looked at an analysis of that tool, and unfortunately, one of the tool questions that is left as a very important factor to differentiate from going or not is if you've had travel. But now that we have community spread, that question is academic. So if you're going to do the online tool, answer the question about travel as a yes, because it doesn't matter whether you traveled or not, you may have community spread, and that may change the instructions that the tool gives you. Next slide. Again, many of you have peak flow meters. So if you don't have a fever and you're just a little bit unwell and you think it's your asthma, you check your peak flow. And if your peak flow has fallen, then likely is your asthma, and you can treat your asthma. If you have a fever with it, then you better not just count on your peak flow. For those of you that don't have peak flow meters, well, this is maybe a good time for you to consider getting a peak flow meter, and this is something you can do to learn what your asthma control is like. You need to know what your best peak flow rate is, but this is a good idea, and if peak flow is dropping, that's when you should be activating your action plan. Next slide, please. The next one common question I get is, well, inhaled corticosteroids weaken my immune system. Here, steroids work in the immune system, and it certainly is true for oral steroids, but it is not true for inhaled steroids. We do know that long-term high-dose inhaled steroids certainly increase the risk of bacterial pneumonia, but they don't seem to increase the risk of viral infections. So, message as far as inhaled steroids, do not avoid them because you're afraid it's going to affect your immune system. Keep taking them to keep your asthma in control. And if you're on oral steroids, which is a small number of people, thankfully, well, first of all, you should be assessed by someone down the road to think about a biologic, because not many people need to be on oral steroids anymore. But if you just stop an oral steroid too fast, you're going to get adrenal suppression. You'll be adrenal suppressed. You may get adrenal failure, and you may have adrenal situation where you can get sick from just that. So oral steroids, if you're on them, you need to speak to your healthcare clinician. Don't just stop your oral steroids. Discuss it with your doc. Next slide, please. What about inhalers? Can my inhaler get infected? Well, you probably shouldn't be sharing your inhaler at the best of times, because all kinds of viruses can be transmitted. But you can give it a wash off, as you know, to clean them. You don't have to get a new one because the virus might be on there. If you've already been exposed, you've been exposed. So use your own inhaler as you would, and I'd just give it a regular clean as you normally would. You don't have to go get a new one. Next slide, please. What about nebulizers? I am a big fan of not using nebulizers in the first place. I know many of you already do. You feel they work better for you. All you're basically doing is using a bit of a higher dose. To me, using a nebulizer means you have to sit there for 15, 20 minutes instead of just taking a puffer with a chamber. So this is a really good time to get off your nebulizer, get a puffer with a chamber, which works just as well. It's been shown in the emergency department to work just as well. It's certainly going to work at home just as well. And the problem with a nebulizer, of course, is a nebulizer sprays out droplets, so that 6 feet might even be a little further. And we learned with SARS that you could transmit particles much further with a nebulizer than just with an MDI and a spacer. So we actually stopped using nebulizers in the emergency room when we had SARS. So nebulizers are a bad idea. I think overall they're a bad idea, quite frankly. They don't add much value. They just increase cost and time. But here they actually increase the risk of spreading the virus. So you probably should get rid of your nebulizer and replace it with an MDI and a spacer or a dry powder. As far as disinfecting your nebulizer, you're the one who's using it, so it probably doesn't matter if you're going to use it, but I would suggest you don't use it. Next slide. But if you need something, of course, you're going to use that. The other common question is, well, should I increase my medications for my asthma to protect myself from getting COVID? Well, asthma medication will not protect you from getting COVID. You can certainly step up your asthma medication if you're activating your action plan and you're getting symptoms, right? But otherwise, you shouldn't be making changes to your medications during the pandemic. You should be speaking to your healthcare practitioner. And you can't even 100% trust your action plan unless you're really sure it's just your asthma that's flaring up and you haven't been infected with the virus. So keep taking your medications. Don't stop them. Don't just arbitrarily increase your dose because you're feeling better, because you're feeling worse. Don't just increase your medications just in case it's not going to help you. Next slide, please. A good question I hear is, I'm sure about my breathing because is it asthma or the anxiety? And it's a really good question, a common issues. Of course, children can't use peak flow meters either. I understand all those things. So we do the best we can. And a peak flow meter might be a very good method for someone who's not sure if it's anxiety or asthma to see if it's their asthma that's flaring up or whether they're anxious. And I do recognize that a lot of us are anxious about this illness. We're anxious about the virus in the first place. We're anxious about having children at home all the time, which makes us crazy. We love them, so these are all things you have to think about. But an objective measurement of your lung function with a peak flow meter will be a very useful tool for you if you're anxious as well. Antihistamines do not affect the immune system. You can take them. It doesn't make any difference. Now, next slide's fine. That's great. How much medicine should you have on hand? Well, you should have enough. And enough right now means a 30-day supply. And the College of Pharmacy across the country has mandated the pharmacist, no matter if you come in with a prescription that says, perfect good, I can have 10 inhalers, they're not going to give you 10. They're going to give you 30 days. Now, the only but to this, and I want to point this out to you because the pharmacist may not think about this, is that 30 days of your maintenance, but you have to have something for your action plan as well. So if you're getting in an argument with the pharmacist, no, I'm only going to give you one inhaler. It's good for 30 days. That's the rules. You say, what do I use for my action plan? And whether you're using salbutamol or you're using budesonide formoterol or Symbicort as your reliever, if you need to have extra, then you have to make sure you have enough for your action plan as well. So the pharmacist is just trying to follow the rules, but make sure you have enough medication for both your maintenance dose and your action plan. Recognize that there are no current supply chain issues for food medications or even toilet paper. So we don't have to hoard all these things. The only advantage to having more at a time is less visits out of the house, and there's some value for that. But overall, you're not going to get more than just about a month's supply or maybe a couple months' supply. So they're not doing anything to you. We just want to make sure that we don't run out. And unfortunately, people were hoarding medications as well, and then that was happening, that pharmacy didn't have enough to give people when they came in. So we wanted to prevent that from happening. Now, one of the concerns you might have is that if I get a shorter prescription, I'm having to pay more prescribing fees because each time I get a prescription, I have to pay a fee. But the governments have set limits to offset that cost. So theoretically, and we'll have to find out what happens, but the pharmacists are not supposed to prescribe you a prescribing fee for the second and third months if you normally get 3 months at a time. Let's have that conversation with your pharmacist if it's an issue. Next slide, please. What about getting a pneumonia vaccine? Well, if you're asthmatic, you should be getting pneumonia vaccines anyhow. There's two different kinds. There's the one the government pays for, the Pneuma 23, and then the Prevnar 13, which is a protein conjugate and a better vaccine. So you should be getting both. But although pneumonia vaccines prevent pneumonia, they prevent bacterial pneumonia from streptococcus pneumonia. It will not prevent you from getting pneumonia from the COVID. So pneumonia vaccines are useful in the long term. You should be getting them if you're on regular inhaled steroids. The data is quite clear, but it's not going to help you, unfortunately, for COVID, and it's not seemed to stop people from dying of COVID because it's not the actual infection. As I told you, it's the cytokine storm, the inflammatory response that occurs because of the infection that does it. Next slide, please. What about if I'm asthmatic and over 60? Well, again, you're higher risk because you're over 60, not because of your asthma. So again, all the same rules. And remember again, it's on surfaces. People can be asymptomatic. One of the concerns I have is these young people who are going out and getting together, and they may get sick, but they don't get sick themselves, but they bring it home to their family, their parents, their grandparents, and can cause illness there, which is disappointing. Next slide, please. So social distancing. I'm repeating myself now. I apologize. No hugging, no shaking hands. The elbow bump is the new hello, but I wouldn't even get that close to people at this point, right? This is a public health response. It's a global response, both in Canada and across the world, 6 feet away. When is it safe to stop isolating? Well, again, 14 days is the time frame from the exposure if you've just been exposed. If you're sick, there's a lot of controversy with that. Part of it is that we would repeat nasopharyngeal swabs to decide whether or not you are okay or not, but with the inadequacy of the number of swabs has been a bit of an issue. So if you're actually sick with COVID, if you had an illness with COVID, if you've actually been diagnosed with having COVID, then you want to speak to your healthcare practitioner and public health to decide when you can stop isolating. If you've been exposed but you're not actually got sick, then 14 days and you're fine to then go back out again. Next slide, please. Can you fly? Well, the answer is no. It's dumb to get into a box where everyone's breathing the same air, even if there is airflow, and they do the best they can, the airlines, and I'm certainly not ragging on them. But try very hard not to travel. If you have to travel, then you want to keep yourself as distant as you can and recognize the people in front and behind you are the ones who are at risk to you. I did actually fly out to Saskatchewan just before this all happened. I brought antiseptic wipes to wipe down my armrest and my tray table, my headrest, and the display for the TV and all those things as I got onto the plane. You may want to wear a mask if you can get onto the plane. That would probably be reasonable as well. Again, stop you from touching your face. So you should try not to fly. And, we're starting to now decrease travel restrictions even within Canada now. So travel and flight is probably going to be an academic conversation for a little while. And this is going to be something that's different for a long time. Next slide, please. Will COVID damage your lungs? So far, most people who get COVID have no problems at all. That's the reality. Most people may not even know they have the infection. The ones that get a mild illness. The very severe infections that require ventilation, intensive care unit, they're going to be sick because they've been very, very sick. And we don't know yet whether it causes long-term damage to the lungs. But if it is going to be, it'll be only those people who have been bad enough to be intubated with the illness and required prolonged life support. So I think as a rule, it's not going to damage your lungs. If you had a mild illness, you don't have to worry about that. Next slide, please. Will it get better when the weather warms up? We're coming into the spring. Influenza is often an illness of the wintertime, although we may have flares in the spring as well. Well, we do know the influenza and the common cold are more common in the winter as well. But the problem is it's not just because of the temperature outside. It's because we spend time inside because it's warmer inside and we gather up together and so on. We talk about the COPD peak of exacerbations that occur at Christmas times. People get together. So it's got to do with groups and gathering of people together with a virus being transmitted. Unfortunately, we know that coronavirus outbreaks have happened in countries that are much warmer than here as well. So if you're hoping that the spring weather and the nice weather we have is going to stop this, that's not the answer. Next slide, please. Treatment. Well, the first thing is, what do you do yourself if you have a mild illness in your home with a bit of a fever, you're not short of breath, and you're taking care of yourself at home? There was some French data that was not substantiated anywhere else that young people who took ibuprofen instead of Tylenol for their fever did worse. It's been looked at in other populations. It hasn't been shown to be a fact yet, but I think it would make just perfectly good sense, unless you're allergic to acetaminophen, that if you're going to use anything for the fever, that you should use Tylenol or acetaminophen. However, if you go back to first principles, why does the body cause a temperature to occur? It causes a temperature to occur to mobilize the immune system to help you get better. So if you just have a little bit of fever, don't take the Tylenol just because you have a fever. You take the Tylenol because you feel really awful to make yourself feel better. We don't take the pill for the number. We take the pill for how you feel. So if you're feeling awful and myalgias and you can't move, then some Tylenol for that would make sense. But you don't have to take it just because you have a bit of a temperature. It's not going to make you better faster. Now, many people are on non-steroidal anti-inflammatory drugs like ibuprofen for other reasons, like arthritis. Health Canada, as well as World Health Organization, has said you don't have to stop those medications unless they're unnecessary. So if maybe you didn't need those medications in the first place, a lot of people stay on medications a long time, you could probably stop that. So the key message here is don't stop anything that you shouldn't stop that's important for your health. Blood pressure pills, inhaled corticosteroids. And I want to talk specifically about ACEs and ARBs in just a moment. Those are types of blood pressure pills that some of you know about. So key message is right now there's no information to stop any medications that you're not told to stop. Next slide, please. That being said, if you've got a flu-like illness and you've had a fever and chills and you have no appetite and you're sweating and you're not drinking very well, you can get dehydrated. And there's this mnemonic for those of your clinicians in the audience called SADMAN. That's called sulfonylureas, and metformin, which are diabetes medications. ACE and angiotensin receptor blockers are medications for hypertension. Diuretics, which of course make you already pee out all your salt, and then non-steroidal anti-inflammatory drugs. And these drugs, in the company of dehydration, cause renal dysfunction and can cause kidney issues. And we should stop those medications when we're sick anyhow. It's part of the recommendation treatment for diabetes, for hypertension, and especially for diuretics because you can get too dry. Now, the ACEs and ARBs are a particular special question because of a couple things. One is in the data, as I showed you, people with hypertension and cardiovascular illness had the highest risk of mortality. And at the beginning, I told you that this virus affects something called ACE2 cells in the lung. And there's a theory that this may therefore cause more of an illness in people who take ACEs and angiotensin receptor blockers that work on the angiotensin system. So the recommendation right now is not to stop these medications if you're on them for a really good reason. If you're on them for blood pressure, especially if there's heart failure or diabetes and nephropathy or things like that, you shouldn't stop these medications. But if you're getting dehydrated and dry, then you should hold these medications as a matter of course. Next slide, please. In hospital, how do people get cared for? Well, mostly this is supportive care and oxygen. And oxygen, to keep oxygen saturation is about 92%. IV fluids are given, but they're given actually carefully because if you give too much fluid, you can actually drown because the adult respiratory distress syndrome is partly to do with too much fluid. There's all kinds of studies going on with antivirals and chloroquine and azithromycin. And you're going to be tempted to say, well, I want to take these medications because they're going to prevent the illness, but there isn't any value. All right. Steroids, you can give your steroids as your asthma dose you could use. We don't use the high-dose Solu-Medrol, Solu-Cortef that some of you clinicians are familiar with giving to asthmatics when they end up in the hospital. Very high doses of steroids actually had poor outcomes, but lower dose steroids that you use for illness is okay. Next slide, please. So there is some in vitro data for medications like chloroquine and remdesivir, which is an antiviral, in terms of affecting in vitro, which means in the test tube can affect viral replication. So that's very interesting because in the test tube, we know if you put chloroquine in, then you get a decreased number of viral replications. So it sounds like that would be a great idea. They tested chloroquine with SARS. They tested a number of antivirals with SARS. It didn't do anything. And recognize that some of these medications are not benign. Azithromycin and chloroquine can increase the QT interval. They can cause cardiac arrhythmias. And there's already been some cases, and I read a case report from Nigeria where people were presenting with overdoses of chloroquine because they're trying to prevent the illness. So don't do it. This is not a medication you take preventatively. This is a medication that's given under very careful circumstances in ICU settings. Next slide, please. And right now, both globally and in Canada, there's a study called the sorry, I spelled that wrong. It should be Solidarity Trial. That's my mistake. And it's a study on hospitalized patients on how to treat. And there's a bunch of different antivirals, and they're also using chloroquine and azithromycin. And there's a study in Canada called CATCO, Canadian Trial for Coronavirus, which is part of this group. There's another study going on about antivirals post exposure, like we do in HIV. If someone's been exposed, we give them antivirals to prevent the illness from happening. These are all being studied very carefully. But what's happening in the world is people are stockpiling chloroquine. People are taking it even though they shouldn't be doing it, and it's a real issue. And people are on chloroquine for other reasons as well, like rheumatoid arthritis and things like that. And unfortunately, we've seen people get sick with coronavirus who had rheumatoid arthritis on chloroquine. So it's not a preventative drug. Please don't take it that way. It's a mistake. Next slide. This one's interesting because this is a very small number of people that they found that got sick, went to the hospital, got admitted, went home, and then got sick again. So there seems to be some people who get a delayed response. This is a very small number, 9%. But if you've been sick enough to be hospitalized and discharged home, you're not completely out of the woods until you've tested negative for the virus and you've been followed for another few weeks. If you get more short of breath, you need to go back to the hospital. Next slide. So back to my key messages. Don't stop taking your medication. Wash your hands. At least 20 seconds with soap and water is great. You don't have to buy expensive sanitizers. Number 3, keep the social distancing. Number 4, okay, isolate if you have any symptoms. Don't give it to anybody you care about. Next slide. That you should clean the surfaces because it can live on surfaces for 3 days. Once you touch things, don't touch your face. Don't touch your eyes, nose, ears, and mouth because you want to infect your respiratory mucosa. If you're sick, have someone assess you to see whether or not you are really sick. If you're sure it's your asthma, activate your action plan. But don't just assume it's your asthma if you have a fever. And of course, the whole concept of staying home and that social distancing we talked about. Next slide. So we're going to get through this together. And funny, of all people in the world, I should quote is Jerry Springer. But he said, take care of yourselves and each other. And I want to tell you one other story. I want to put all this in perspective, that we will get through all this. Maimonides was one of the first physicians that we've ever described in remote times. And there was a period of time back then where he was the valued physician, and he was the physician of the king. So the king he used his physician, but then from another group of people that brought their physician said, well, our physician's better, you should use him. So the king didn't know what to do, so he said, you know what, we're going to have a doctor off, and we're going to have a competition between the two of you to decide who's better. So the first physician gave Maimonides a poison. But Maimonides was pretty smart, and he actually took some charcoal beforehand, and he didn't die. So then Maimonides gave the other physician a glass of liquid. And the second physician took the glass of liquid, and he said, I don't feel bad. This is really weird. How can I not feel bad? I should be feeling terrible. So he started worrying, and he stopped eating because he was worrying so much, and after a week he died. And the king said, well, what did you give him? He said, well, I didn't give him anything. I would never harm another person, but what I did do was give him something to make him worried, and he actually worried himself to death. Please let's not do that to each other. Let's take care of each other. Let's look after everybody. Let's look after our families. Let's prevent the illness from spreading more. We can do this so we can look after each other. Thank you so much to the Asthma Society for allowing me to do this. And Jonathan, I'll let you finish up.
Awesome. Excellent. And thank you so much again, Dr. Kaplan, for agreeing to do this. And thank you to everyone for joining us today. I know we went a couple of minutes over. Dr. Kaplan, if you want to stick around for a couple of minutes just to answer if there's any auxiliary questions in the attendee chat
Absolutely.
there as well, just after I finish up here. Obviously, we thank you for everyone for coming. Obviously, with the current COVID-19 situation, people with asthma are depending on us more than ever. Our helpline service is actually 6 times, I believe that's even more now, the volume of inquiries, and we're working tirelessly throughout the weekend to make sure that we support our community during these uncertain times. As we are a charity, we work through the generosity of people, like everyone on this webinar today. If you found this webinar useful, please consider making a donation. You go to asthma.ca/donate. And if you want to know more, you can go to www.asthma.ca, and we have a important thing for people with asthma called the Asthma Canada Member Alliance. Send regular updates, education, advocacy, and research on the stuff we are doing, and that we're really proud of. And we hope you head over to our website to check out not only our position statements on the COVID situation, but all the other interesting and wonderful things that we have on our website there. That concludes the majority of the webinar today. And Dr. Kaplan, is there any questions in the attendee chat that you would like to have a answer to?
Yeah, so some really good questions. Thank you. So some really good questions in here. Unfortunately, I may not be able to get to all of them, but a couple things. And a lot of that is what do I do with stuff coming into the house? Talking about, should I wipe things down? And I think you should, anything that comes from outside of your house that you haven't been able to know that has not been exposed, you probably should give a wipe down as you bring it into the house. Something practical and others to do that. Not stopping the medications came up a lot. children who have asthma, are they more susceptible? So far, this is a disease that, for the most part, is not really affecting children very much. They're getting a free ride on this. So you're probably okay with your children, even your asthmatic children, quite frankly. But again, those asthmatic children, even if they don't get sick themselves, can give it to somebody else, right? So that's probably pretty important. Comorbidity was asked about. That means any condition that makes it more have another medical issue that could make their overall prognosis poorly, and that's mostly cardiovascular disease and diabetes, as we said. The laboratory work that seems to imply worse outcomes in the hospitalized patients are people with low lymphocyte counts and low eosinophil counts. But that'll be people who are sick enough to be in the ICU, and it's a prognostic tool. It doesn't matter if you have a low lymphocyte yourself already. Being on hydrocortisone for adrenal insufficiency already, would that affect your outcomes? Well, yes, chronic steroid therapy would probably make you somewhat immune deficient, but don't stop it because you need it, because at this point, you are replacing your regular steroid. You're not actually treating anything, and this whole other mechanism to try to get off the steroid in the long term. As many of you know, your doctors are not bringing patients to the office so much for things anymore. They're doing virtual visits when they possibly can. So you may get phone calls from your doctors about things instead of coming to the office. I know it's different, but it might be the right thing for us to do in the long run. Asthmatic patients are not more likely to need a ventilator. That was found from the Chinese data. Just looking at the last couple of things. Pulmonary functions in pneumonia. You may get some restriction from pulmonary function from pneumonia as opposed to worsening obstruction. So it may change things a little bit, but we're not doing spirometry right now anyhow. That's one of the major things. I've stopped doing consults for respiratory medicine now because I can't really do spirometry right now, and we should be holding off on doing spirometry because it blows the droplets into the air. James Kim on message reminds us that SGLT2 inhibitors is missed on my list of diabetic medications you should reduce when you're dehydrated. So thanks, James. That's another kind of diabetes drug. And I think that answers most of the questions that are relevant there. I know that we are recording this, so I'm not sure what's happening to this as far as the website for that question. Listen, thank you very much for all your time and paying attention to this. Stay safe, wash your hands. Biologics and COVID-19, remember I talked about asthma biologics don't affect the immune system per se. The rheumatologic biologics may affect a little bit, but so far the recommendation from Rheumatology Society is not to stop your medications because the illness can then cause worse things happening. But as you know, if you're sick, you should stop your biologic anyhow as far as the non-asthma biologics. So if you get a viral infection like a cold, you're not supposed to take your next dose of rheumatologic biologics. So you should do the same thing for here. Okay, I think I'll sort of close down now. Thank you so much for all of your time and attention. Thank you to the Asthma Society for arranging it, and everyone stay safe.
Excellent, and thank you, Dr. Kaplan. And just a reminder that this webinar, like Dr. Kaplan said, is recorded and will be uploaded to our website later on this week. And again, we thank you all for coming. Again, please visit www.asthma.ca for more information. Thank you, everybody. Have a great week. Bye.
Bye, everyone.